discussion for questions. Thank you very much. The mic is yours, Sherif. Fadlan.
Excellent, excellent. Thank you very much for the organizing committee. And thanks, Dr. My friend, dear friend, Dr. Sameh, for giving me this opportunity to interact with my fellow Egyptian colleagues, which I really miss for a long time. So I am going to talk, the technical issue started. Going to talk about gonadal insufficiency, if the slides works. Yeah, so I'm going to talk about the management actually of hypogonadism, but obviously to start with, as endocrinologists, we have to always remember the physiology. So I will touch on the physiology and touch on the causes and the clinical presentation of gonadal insufficiency in children. Physiology, I'm sure you all recall this figure, the hypothalamic pituitary gonadal axis. And the hypothalamus releases the gonadotrophin releasing hormone, GnRH, which will stimulate the pituitary gland to produce gonadotropins, LH and FSH, that works on the gonads to produce sex hormones. And of course, any lesion or any defect along this pathway will end with a low level of sex hormones. But as you would imagine, if the defect is up there on the hypothalamus or the pituitary, then beside the low level of sex hormones, you will get low LH and FSH. So it is hypogonadotropic hypogonadism. And if the defect in the gonads, because of abolishing the negative feedback, then the LH and FSH will be high. So you will get hypergonadotropic hypogonadism. And that is always the first step in differential diagnosis, if you want to work out the diagnosis. Also, I want to point out that in boys or male, the FSH and LH, FSH work on the Sertoli cells and seminiferous tubules, and these two causes the testes to enlarge. And at the same time, working on the Sertoli cell, it produces the spermatogenesis. And the Sertoli cell secrete the inhibin B, which is the negative feedback at the pituitary level. And therefore, inhibin B level is a good marker of the function of the Sertoli cells. LH, on the other hand, works on the leading cell, and this will produce testosterone, which with its well-known systemic effect. But what I want to point out is another testosterone that is secreted inside the testicles, intratesticular testosterone, which is important for spermatogenesis and also important in testicular descent. So therefore, you expect a child with lack of LH, they will have undescended testicles. And at the same time, if you want to treat this undescended testicle with testosterone, it will fail because you don't need the systemic testosterone more than you need the intratesticular testosterone. Remind you about mini puberty. So the puberty we all talk about after age of 8 in girls and 9 in boys. This actually the third puberty, because there is first puberty during fetal life, and the second puberty is in the first 4 to 6 months after birth, where the pituitary surge FSH and LH, and this cause the penile enlargement and testicular descent and volume, like I've mentioned earlier. And also it is important for the gonadal development, particularly Sertoli cells and ovarian follicles. And the mini-puberty is very important for future fertility. So children who lack for a reason or another, mini-puberty will have problem with fertility later in life and they will need intervention. Puberty itself, first thing to come to your mind, puberty is secondary sexual characteristics and fertility. But always remember, it is also very important for growth. So hypogonadal children, not all, but most hypogonadal children are short. And also it is very important in bone accrual. So you can, if you got hypogonadism, then children can get osteoporosis. Causes, you can, when you think about it, it can be at any level, but for, as I mentioned early, for the central or secondary or hypogonadotropic hypogonadism, there will be problem in the pituitary or the hypothalamus. All this list in front of you, including some syndromes, like Kalman syndrome, the most common one, with not most common, most famous, is rare, with anosmia, but it can happen also without anosmia. But the one in bold, these are the most common we see. The CDGP, constitutional delay in growth and the puberty. This is the most common cause of, if you like, temporary hypogonadotropic hypogonadism. And also chronic illness like diabetes or untreated hypothyroidism or untreated chronic illness. Gonadal problem, the most common we see is Turner syndrome, less common Klinefelter, and obviously after chemo and radiotherapy. And we'll go now briefly to the clinical presentation. So in neonatal period, as mentioned, micropenis and cryptorchidism, undescended testicles. In teenagers, it presents with delayed puberty. And as I mentioned, constitutional delay of growth and puberty is more common. It happens about 2% of the population. And in fact, it is extremely difficult to differentiate between constitutional delay and hypogonadotropic hypogonadism. And practically speaking, only time will tell which one or the other. So those who did not develop secondary sexual characteristic after age of 16 normally have hypo or usually have hypo rather than constitutional delay. It could be presented as part of other pituitary hormone deficiency, and our colleagues in neonatologists see children with hypoglycemia, investigating them, they find low cortisol or hypothyroidism, and then check the gonadotropin. Instead of being high in the first 4 months, it is low. So this is an early diagnosis of hypo. My talk will focus mainly on the management. And I thought when I was doing this presentation, I better put it as management at the time of presentation. So first in the neonatal period as micropenis or microphallus. Most commonly, we use intramuscular testosterone. We prefer to use propionate because the other testosterone, the enanthate, have castor oil and benzoate. Although we still use it, but with caution. But we never use sustanon. Sustanon is the very most popular testosterone injection because it contains benzyl alcohol, which can cause damage in the neonatal period. And this is clearly mentioned in the leaflet of sustanon. However, It depends on the availabilities, and I know some colleagues are still using it as 25 milligram monthly for 3 months. 25 milligram is very, very low dose, but there are many evidence that it can promote penile growth when it is used in neonatal period or early childhood period. You can also use testosterone cream, and there is many preparations. And with the low strength, use it for 6 weeks. High strength, use it for 3 weeks. But it's messy because you have to wear gloves, applied on the penis once or twice a day. Normally, mother is the one using it, and mother, you don't want mother to be exposed to testosterone. But again, it depends on the preparation available. Personally, I prefer use intramuscular testosterone, propionate if available. Undescended testicles, of course, surgery is the preferred option. And surgeon normally think about surgery after 6 months for the reason I mentioned earlier, the mini puberty, because you would expect in partially descended testicles with the surge of LH and FSH during mini puberty, hoping that the testes will go down a little bit, but definitely, preferably, operate on the undescended testicles before age of 1 year. Other option I have used, and many of my colleagues have used, but we don't really use it much now, is HCG, human chorionic gonadotropin, which is in effect is LH. Because as I mentioned, LH increase the intratesticular testosterone and then help the promote the descent of the testicle. So normally you should use it only on very mild cases of cryptorchidism, i.e. when the testes are felt in the lower inguinal region. And this is the dose for 5 weeks. It's relatively safe, but there are few reports about germ cell apoptosis and future infertility, but this is very rare. If you think about it, the cause of hypogonadism of undescended testicle or microphallus is actually lacking LH and FSH. Therefore, in theory, we should use FSH and LH for treatment. And there was few protocols, few study, like in front of you, using these doses, and with some success, actually, some promising results. But again, it is few case report, and we can't generalize the use of it. And in addition, availability of LH and FSH is a problem, is expensive, and there is not much expense with it. But something I have to mention just in case. In childhood, for children who have hypogonadotropic or hypogonadism in general, normally we don't do much. However, perhaps it might be useful if a child have severely or very, very, very small testes. In this case, you want to enlarge the testicle in order to promote fertility in the future. And few studies used recombinant FSH 3 times daily for a year with some success. But again, this is few studies, long-term effect is not clear, and we cannot generalize the use of it. But you should consider for, and I used it before in a child with a testicular volume between 1 and 2 milliliter, very, very, very small testes. most commonly is puberty. We'll start talking about boys. So testosterone, there are mainly three intramuscular testosterone. Intramuscular testosterone, we've been using it for years and years and years, and we have lots of experience with it. And we can titrate the dose easily. We can monitor compliance because it is injection. However, it can cause pain in the injection site. And as you would expect, it's not very physiologic because you give high dose every month or so. And also you have to monitor the liver function tests and full blood count for possible polycythemia. And then some preparation like Nibidu, which we don't use actually, can cause embolism. Problem with testosterone is that it will induce secondary sexual characteristics, but it will not enlarge the testicles. It will not promote spermatogenesis, and therefore the testes will remain small, and you are not actually improving fertility. The three testosterone we have, or four, perhaps, is the enantate, is the most popular one, propionate, that I mentioned for neonatal period, and the sustenone, which is a mixture of esters of testosterone. And when we use testosterone to induce puberty in boys, we want to mimic the normal pubertal progress. So we should give it slowly over 3 to 3.5 years, starting by small dose and then gradually increasing. Because you don't want premature closure of the epiphyses, so it should be small dose and gradual increase. Enantate is the most popular one we use up until we reach maintenance dose. After 3 years, we can use the Nibidu, which can be used every 10 to 14 weeks. We can monitor or change the dose based on the trough level before the next injection, and you are aiming for testosterone level at the low normal. There are other preparations you will hear about it, about transdermal, and it's better because it is more physiologic, and there are plenty of evidence in adults, but not in children, and it is very difficult to use. To induce puberty is easier to use for maintenance, but imagine a teenager boy, you want to apply testosterone gel on their shoulder and arm and ask them not to dry the arm for half an hour and no bathing for 6 hours after that, and don't touch it because you can transfer it to somebody else. It's messy, it's difficult, it's not practical. That's my personal view. The gel is different from cream, and you have to remember this. The cream we mentioned for penile enlargement in neonatal period, but the gel is for inducing puberty. Few studies have used this protocol with success, but as I mentioned, I think it's mainly for maintenance rather than for induction of puberty, practically speaking. Testosterone patch is another one, but again, I think is more appropriate for adult use, and particularly the scrotal patch, which will be too large for the immature small scrotum in children with hypogonadotropic hypogonadism. You hear about oral testosterone. Not too bad, but not the best option because it have variable absorption. And there is large degree of personal variability and depends on food intake. It is licensed only for pubertal induction. My personal view on this, you can use it for just the induction, but not for the maintenance. And there is a recent preparation, Jatinzo, which is more stable, but is currently licensed for those over 18. In any case, when you induce puberty, particularly with hypogonadotropic hypogonadism, you should try time off testosterone, because 10 to 20% of those boys recover spontaneously. So you ought to say, for example, after a year, stop for 3 months and see if there is testicular enlargement or not. But even though, you have to follow them for a long time, because they might improve transiently and then relapse again. And the best indicator for the endogenous testosterone production is the testicular volume. So you ought to measure testicular volume regularly, and once you see that it's enlarging, then you might consider stopping the testosterone. Again, here, I talked about replacing testosterone, but actually, if you think about it, if the problem is in the pituitary, we should actually use LH and FSH rather than using 6 hormones. And therefore, some trial about using LH and FSH in different protocol, including protocol using HCG and insulin pump, and with some success, but it is very expensive, not standard treatment, is not available in all countries, and the studies we have are not large enough actually to say, yeah, that's the way forward. But this another use, the other one about HCG now is about the LH and FSH, and as I mentioned, human chorionic gonadotropin is the equivalent for LH. The question is, which one is better? To start inducing puberty using LH, FSH, or use testosterone and then later, once they want fertility, then you give LH and FSH. This is the largest study, and I'm saying largest, although only about 60 patients in it, German study. And for the purpose of the time, I'm not going through in details, but the bottom line is actually there's not much difference whether you start by testosterone and later give LH and FSH in comparison to start with and continue with LH and FSH, which means actually what we are doing, we should continue doing by, in boys, we give intramuscular testosterone, induce puberty, maintain puberty with intramuscular testosterone or patch later, and then think about fertility using LH and FSH. And if you want to take a photo of this, that is summarize all the current testosterone preparation available and its use and its advantage and disadvantage. Then how about girls? Girls, again, same principle. We should start at the time of puberty and we should go slowly over 2 to 3 years. And we have only 3 preparations for estradiol. In the UK, we used to use ethinyl estradiol. That's the most common one. We've been using it for decades and decades. And some manufacturer can produce very, very small dose, 2 microgram. And I repeat, it is microgram, not milligrams, because most of preparations you have in oral contraceptive pills are in milligrams. This is micrograms, and equivalent to the transdermal matrix patch is becoming more and more popular, and perhaps is better than the oral ethinyl estradiol. However, again, it depends on the availabilities. So, for example, in UAE, the patch is not available, but we have the ethinyl estradiol, but only 10 microgram, not the 2 microgram we had in the UK. Then you should introduce progesterone, but after completion of breast development, because if you start progesterone early, the breast will stop growing and its shape will be odd. And therefore, you shouldn't actually use oral contraceptive pills whatsoever for inducing puberty in girls. And the 17-beta estradiol, which is the batch and the tablet, are more physiologic than the phenyl estradiol. And because it have also greater uterine volume and better breast development and better bone mass. And problem with it is the patch may fall when it's cut too small. Adolescents don't like to have patch and visible to everybody. And we don't know much about the oral 17-beta estradiol, so patch we use if available. If phenyl estradiol, we had much more experience with it, safety profile well established, but again, it is the availability, and perhaps patch is superior. It's becoming more expensive, particularly if you want to get the 2 microgram dose. Take a picture of this, take a photo of this table, because that is how to use it to induce puberty. And the bottom line is you have to start with very, very small dose, go gradually every 6 months, up until you reach the maximum dose, which is equivalent to 10 microgram phenyl estradiol. After 2.5 years, I prefer. And then you maintain with either contraceptive pills or human hormone replacement therapy. The oral pills are cheaper and readily available, and I prefer it over the HRT. You is preferably to use the oral contraceptive pills with low estradiol dose 20 or 30 microgram, and it's better to use like 3 months back to back, and then stop to allow uterine shed. Some, particularly in Switzerland, some colleagues there, instead of using estradiol, they say, well, problem with the GnRH or problem with the LH and FSH, we use GnRH, and they use it in a pump, or they use several protocols with some success, but again, very expensive. We don't know the doses, small studies, we cannot recommend it. For the time, I'm aware of the time, so I will conclude quickly. Diagnosis can be challenging, particularly of central hypogonadism. For girls, we prefer matrix patch. If not available, then oral phenyl estradiol, then oral 17-beta estradiol. For boys, testosterone enanthate or ester for the testosterone for induction of puberty. GnRH and FSH is still considered as experimental. Perhaps only you should consider FSH for boys with very, very severe form. And again, it is the local availability and expertise often guide what you should use. And the last slide is, please be minded of these pitfalls. So don't use oral contraceptive pills for puberty induction in girls. And do not introduce progesterone until full breast development. And don't start with high dose of estradiol, because this will make the breast like longitudinal rather than round. It has to be small dose and gradually increasing it. And in boys, don't use sustenance in very small kids, and don't use the libido for induction of puberty, the very long-acting testosterone, and don't confuse gel with ointment. And I would like to thank you very much, and I'm happy to take any questions.
Thank you very much, Dr. Sherif. But let me ask you a very simple question. When do you usually start inducing puberty in girls and boys? The age of?
Yeah. Normally we say, it depends on the diagnosis, of course. If you know the diagnosis before puberty, and you know that they will need pubertal induction, normally 13 for boys and 11 to 12 for girls. However, I usually delay this if they have growth hormone deficiency together with the sex hormone deficiency. In this case, I delay it for a year or so to give more time for growth hormone to work in order to improve the final adult height. That's my personal practice. Some people might disagree.
No, thank you very much. This is my usual practice as well. Thank you very much. Dr. Sherif, for the sake of time, I will collect all the questions and I will send you email asking you to answer the questions. Your presentation was very clear, to the point. Thank you very much. Thank you very much indeed, Professor Sherif. ألف شكر.
Thank you very much. And by the way, I'm not professor, but thank you for calling me professor. Thanks a lot, and happy to answer any question.
You're senior pediatric endocrinology consultant.